Yeah.
All right. Oh, we got participants already. Y'all are on time and ready to go. I love it. Good morning. Good morning. We're gonna let y'all come into the space. As you do so, pretty please feel free to introduce yourself in the chat. We'll get started in a very short minute here. So thank you for being here. All right. We'll give it just maybe another minute or two, just for folks to come in. While we do that, I will just kind of chat about some housekeeping things. Um, please remember to mute yourself. Um, there will be a point where we will open up for open discussion. You can raise your hands and we will chat at that point, but that you are on mute. Good morning, Rebecca. I see you. Good morning, Lauren. Good morning, Trisha or Tricia. I'm not sure which way you pronounce it. Olivia, brilliant wording. So we will give it's 8:02. I'm going to wait till 8:03 and then officially get us started, okay? Also, please feel free if you have questions that come up as we are talking about this important subject, please make sure that you put those in the chat as well so that we can try to get them addressed. All right, so I think probably another 30 seconds while I organize my life and we will get started. All right, that is our 30 seconds. Good morning. Thank you for being here again. My name is Bridgette Picou. I am the stakeholder liaison for the World Project, where, as you know, we focus on women and girls living with or with reasons for prevention from HIV. I am super excited to talk about this topic because it comes up and it doesn't come up often enough, in my opinion. And it's something that I think we need to be discussing frequently and with vigor because there's so many questions surrounding HIV and menopause. So welcome to the roundtable. Thank you for being here. We're going to be talking about what we know and what we need to know. I have a fabulous panel of guests that will be joining us and leading the conversation. I'm just here to moderate and ask some questions. So we will start, and I think we'll do just a quick self-introduction. I'll let each of you go tell just a little bit about yourselves so that folks know who we are and how we come into the space and to be connected to HIV and menopause. Shema, why don't we start with you?
Thank you so much, Bridgette, and hello, everybody. I am joining you from very dark and very cold London. It's getting towards 4:00 in the evening here. It's a real pleasure to be here today to talk about something that is really important to me, both personally and professionally. So my name is Shema Tariq. I'm based in London. I am an academic who has spent 20 plus years working on research on how we support the health and well-being of women living with HIV across the life course, so from pregnancy right through to older age. I founded and lead one of the UK's largest specialist HIV and menopause services, providing integrated care for women during this important life transition. And I think we all had this conversation before we joined. I am deep in the trenches with you all. I'm a perimenopausal woman. I turn 50 next year, and am definitely feeling all the symptoms, and you will notice my brain fog as I talk, almost certainly. But yeah, can't wait to have this conversation with you all.
Brain fog is probably the worst of everything. And I see nods. So, Heather, you're nodding like vigorously because you know, like I know. So why don't we go ahead and have you introduce yourself real briefly?
Sounds good. Hey everyone, my name is Heather Ray O'Connor and I use she, they pronouns. I am currently located in Lexington, Virginia. I am a non-binary person living with HIV, diagnosed in 2016. I live with several chronic illnesses aside from being diagnosed with HIV, and I am currently in perimenopause. And 1000% yes to the brain fog and to also the frustration that it creates when you are having that brain fog and not able to, articulate what you're trying to say. And then that feeling of just being like, what, like, why am I not, you know, able to say what, and so that frustration, I feel I'm having it now. So, yes, absolutely. I have two kiddos, Aurora and Zephyr, a 6-year-old and a 5-year-old, and they're awesome and
Excellent
happy to be here.
being here. I love when you're in this space, Heather. Um, Miss Dottie, go ahead and have you introduce yourself. Your hair looks fabulous today, by the way. I didn't say that earlier.
I appreciate you. Thank you so much. And good day, everybody. I'm Dottie Rains-Dowdell. I am the program director for the New Jersey HIV Planning Group. And how else can I? Yes. I'm also a woman living with HIV for about 34 years. I turned 50 in October, and I was diagnosed at 16. And I also have done some research in Black women in HIV and just recently graduated with my doctorate in health science. I have a 31-year-old, yes, thank you, a 31-year-old son, and an 8-year-old daughter. And I'm also menopausal, and it is definitely I am on the struggle bus most days with the brain fog and just the intense emotions, and we'll get more into that later on throughout our time together. And thank you for having me. I'm excited to be here. I am so excited to be here.
So hey everyone, my name is Kim. Kim Canady. I am from Brooklyn, New York. I'll be 39 in 16 days. So on December 7th, and I've also been living with HIV for 30, well, it'll be 39 years. So I'm a lifetime survivor, also known as a dandelion. Um, have a 15-year-old. He'll be 16 in January. So please pray for me as I am also going through perimenopause. I feel like this is like an AA group. Hi, my name is Kim, and I'm also going through perimenopause. This is how it's feeling right now. So everything what y'all are saying, I'm like, yes, this is, I found my tribe. And as I'm figuring out what this looks like, also with being a woman with Jesus. It just happened. Living with HIV since birth, we are walking through uncharted territories as we are figuring out this perimenopause, and I'm happy to be here and a part of this conversation. So thank you.
Absolutely. Thank you so much. I did not say I'm in the trenches. I am 53. I turned 53 the day before Dottie turned 50. So we're little Scorpio twins. But the thing is that so many of us are in it right now. Or the scarier part is that many of us are in it and don't even realize that that's what's going on with us. And we'll get a little bit more into why we think that is. I have recently been doing a lot of talking about menopause, and it is a subject that I've become passionate about. And so I'm really looking forward to this conversation. Shema, I believe you have a short little talk that you're going to give us about basics and all that good stuff. And so I'm happy to turn it over to you if you're ready.
Yeah, I am. I'm going to see if I can share my screen,
You should have
which
it
I
if you
should be
don't
able
let me
to.
know.
Yeah, I do. Just
Okay.
bear with me.
Perfect.
Ye-
And the rest of
ye-
us will go off camera while you do that. So there's no
Great.
distraction.
Can you see my slides?
Yes, we can. It's in uh, review mode, not presentation mode, though.
Oh, this keeps happening. Wait a second.
If you click from beginning, it should pop up for you.
Okay. Let me try that again. Sorry, just bear with me.
Oh, it's okay. I am the worst when it comes to trying to share screen and get into, trust me, we are all,
Is is that working now?
we
Are you still seeing the review screen?
don't see anything right now.
You're not seeing anything. That's even worse than before. Right, 2 seconds. Let me try and do this.
I had a whole like 3-minute debacle with this kind of thing, so don't feel bad.
It's just so crazy. Right, let me just try and do that again. Um,
It's so fine. Yesterday, my hands were so sweaty because I was having like a hormone rush, and I went to I was on a webinar and I tried to touch my phone and it like made it go crazy. It happens. We're doing great.
Indeed.
yeah. How's that? Any luck?
If you, I think from here, you may be able just to go to from beginning.
I have just tried to do that. Let me just, is that making any difference? No.
I think that unless you have speaker notes you don't want us to see, I think that mode is fine. Or if you want to
Okay.
send them to me real quick or CC, we can do the sharing.
I've sent them to Cece.
Okay.
Or she
But
can make the screen bigger as well, and
yeah,
it'll
let me
cover
just
the
see if
other
I can do,
side.
let me see if I can do that. Just let me make this.
And Heather, to your point about hormone rushes, I am parenting again. I'm raising my grandson, and um, I have never met a child who has the ability to make me crazy as quickly as he does. And I think it has to be the menopause because I am not the person that I think I am when we get into it, and it's wild. There we go. We're in good shape.
Absolutely.
Is this going to work? So apologies. This is just sharing it in the review format, but I can't seem to make it work any other way.
We're perfectly fine.
Great, let's do it. So I'm just going to take maybe 15 minutes at the most to just get us all on the same page. I'm going to ask if you have any questions, note them down, and we can talk about them after I've just gone through these slides, because I think all of us will be able to talk about these questions together. So I just want to give you a whistle-stop tour on menopause and also on how menopause plays out in the context of HIV. And what I'm going to be sharing comes from the research that I've done, but also my clinical experience of spending sort of 10 plus years working with women and supporting them through this important transition. So I've already told you about me, so I'm not going to talk about that anymore. One thing to say is that I can't give individual medical advice, but I can give generic advice about menopause, but I can't just give individual advice. But I'm really happy to talk more generically. I always start off by being super clear that menopause happens to people, and those people are anybody who has ovaries. So that's cisgender women, trans people, and also gender non-conforming people, and those who are intersex. You will hear me refer to women a lot during my slide presentation. And that is primarily because the vast majority of research has been undertaken in cisgender women. It's not because I want to be gender exclusive. So please take it as read that a lot of what I'm saying is going to apply to anybody who has ovaries. And when I refer to women, it's because that's where the research has been done. So what are we going to cover today? I always assume a level of zero knowledge when it comes to menopause. And I say that as someone who trains doctors, and doctors have zero knowledge of menopause. So that's what I sort of start as my sort of like basis. So I'm going to assume that none of us really know what menopause is and explain what it is. I'm going to talk to you about what symptoms people experience. I want to give you some data on how menopause impacts people living with HIV. And the thing that you really want to hear from me is how can we improve our health and well-being during this stage of life? So let's start off. What is the menopause? So menopause is, so let me just get rid of these guidelines. We don't need that, nor do we need this. That's better. So menopause, very simply, is the time when our periods stop and we no longer have the potential to get pregnant. And for most people, that happens between the ages of 48 to 52. So in the UK, the average age of menopause is 51. In America, it's slightly lower at around 48 to 49. And the reason it happens for the vast majority of people, this is a biological transition that happens as a result of ovarian aging. So as we get older, our ovarian function begins to decline because we're getting older. We don't have as many eggs to release, and we end up going through menopause. So we run out of eggs, ovaries stop working, and they also stop producing the female sex hormone, which I'm going to talk to you a lot about, which is estrogen. It's not always due to aging. So there will be a proportion of people who experience menopause either because they have their ovaries removed surgically, for instance, for ovarian cancer, or because they have medically induced menopause. We see that commonly in people who have survived breast cancer, who are on breast cancer treatment for hormonally dependent breast cancer. So there are medical and surgical reasons for menopause. But for the vast majority of us, this is something we go through as we get older. And one thing that I'm always clear about with people is that there are doctors who believe that menopause is a deficiency, like a hormone deficiency, and they treat it as some sort of disease. I am not that doctor. I 100% believe that menopause is a natural transition for most of us. It's a social transition. It's a biological transition. It's a hormonal shift. Yes, it's important, but it is part of our life's journey. And I don't think that we're deficient in any way when we go through menopause. And I don't think we absolutely have to take hormones. So I always make that clear. That's my particular perspective. Hormones can be super helpful, but I don't think there's any reason we have to take them. So this is data from the UK, but it will broadly apply to people outside of the UK as well. So in the UK, average age of menopause this is the day when you have your last period, is 51. As I said, it's a bit lower than that in North America. About 75% of women during menopause will experience hot flushes, or in the US, you call them hot flashes. I've got to remember that. And 1 in 4 women will experience hot flashes that are so severe that they adversely affect them at work. What people don't realize is that menopause symptoms actually aren't something that you have for a few months and then they go away. The average duration of menopause symptoms are between 4 to 8 years. So this is actually quite a significant length of time that we're going to be affected by this. I'm going to do a slight detour to tell you that only 5 other species of animal experience menopause. And this is a real test of my poor, tired menopausal brain. But it's orcas, beluga whales, pilot whales, another type of whale that I can't remember, and a species of orangutan. And they're the only other species that have menopause. So for the majority of mammals or other animals, they don't have a life beyond their reproductive lifespan. So when you can no longer get pregnant, there isn't a life after that. But we are one of the few species where We can no longer get pregnant, but we still lead sort of substantial period of our lives after that. And people think that, so there's this thing called the grandmother hypothesis. So all of these animals who have menopause share one thing, which is they live in communities. They're sort of very social animals, and they tend to rear children in communities. And so that brings up this thing called the grandmother hypothesis. And I love this because it puts a positive spin on menopause. So the reason biologically or evolutionary why we go through menopause is because you need large numbers of wise older women who aren't going to be burdened with pregnancy or bringing up very young children, because they are essential for the success of that community as a whole. We do a lot of the looking after, we bring the wisdom, and we are essential to the success of that species. So I really like that framing of, we need older, wise women. So what happens during menopause? So this is the graph that I show all my patients. So there's two graphs I show when I see people in my HIV clinic. I do the CD4 and viral load graph and what happens when you go on treatment, which many of you will be familiar. And this is the second graph. And this is what happens to your hormones as you get older. So I just want you to focus on the orange. So the orange is your estrogen hormone. So this is the female sex hormone that has lots and lots of positive effects on us. For the majority of people, not all of us, during our premenopausal phase, you have a predictable rise and fall of your estrogen, and that corresponds with your menstrual cycle. And for many of us, that will be regular. Some of us, it isn't as regular. Then what happens, usually from our early 40s onwards, can happen earlier than that, but from our early 40s onwards, our ovaries stop working quite as well as they did because they're getting older. There's fewer eggs to release. The eggs aren't of good quality. Unlike men, we don't keep producing eggs. We're just born with a certain number of eggs, whereas men produce sperm all their lives. And then what happens as the ovaries start to, a colleague of mine calls it going into retirement, which I like it. I like that phrase. So as your ovaries start to retire, you get this really sort of erratic rise and fall of your estrogen. So it sort of spikes and then it drops. And from one moment to the next, you don't really know what your hormones are doing. And we call that phase perimenopause. And that's where you get your unpredictable periods. So you might not have a period for months and then it comes and it's really, really heavy. And then you might have another one a couple of weeks later and it's really, really light. And this is when you get your peak of symptoms. So commonly, this is when you start getting the hot flashes, the night sweats, the sleep's disturbed, your brain fog, your aches and pains. All of that's happening at this stage. What happens, you then have your last ever period. So menopause is actually only one day in your life. It's the one day where you haven't had a period for 12 months. The day after that, you are in your postmenopause. As you reach that postmenopause, your estrogen hormone drops and it's low. It never goes back to what it was when you were younger, but it's stable and low. And our bodies are much better at dealing with things that are stable than they are with this sort of more crazy, chaotic hormonal profile. And I think that's really important to say to people because it explains why perimenopause can be such a difficult time for many of us. It's why we get loads of symptoms. And I think it's really helpful when we're trying to explain to our loved ones, to our friends, to our work colleagues, why this is so challenging. It's because our hormones are all over the place. It's a bit like being a teenager again, but with 10,000 times the responsibility, unfortunately. And then there's a good news story here, which is that for most women, not all people, but most people will reach a stage where their symptoms go because their estrogen levels just peter out and they start being much more stable. And this is where lots of people say that they enter this sort of second spring and life is so much better. So lots to look forward to. So one thing I need to get across to you is menopause is not just hot flashes. And those of you who are perimenopausal know this from experience. hot flashes are important. 80% of people get hot flashes. There is some evidence that people living with HIV have more hot flashes than those without HIV. But even if you don't have HIV, 80% of people are still going to have them. They're super common. But there are a whole host of other things as well. So we have estrogen receptors all over our body. And that means when we go through menopause and there's a dip in your estrogen, you're going to get symptoms everywhere potentially. So we've talked about the hot flushes and sweats. And the reason we get that is because the parts of our brain that control how we regulate temperature are dependent on estrogen. We lose estrogen and we can't really control it. We can't deal with the changes in temperature as well. We also develop mood changes as well, especially difficulties in regulating our emotions. So those of you, I certainly get this, is I can go from 0 to 100 in terms of rage, which I never had before. Like I only have to drop something and it's like the world has ended. And it's because our hippocampus and our amygdala, which are parts of our brain, our frontal cortex, these are all parts of the brain that help us regulate emotion. They're really, really estrogen dependent. So again, we're losing that hormone and it's really affecting our ability to regulate our emotions. I have very young children at home. I have a 5 and a 6-year-old, and I would say my emotional regulation at the moment is very similar to my 5-year-olds. Joint and muscle pains, we have estrogen receptors in our bones and our muscles. Brain fog, again, due to the loss of estrogen to the brain, but also because we're not sleeping. We often have a lot of stress at this time. Sleep disturbance, feeling like our heart is racing, feeling tired, because honestly, why wouldn't you feel tired with all of this going on? And then also the things we really don't like talking about because it feels too embarrassing and we just have to get this out on the table: sexual issues and bladder issues. So during menopause, really common to get dry vagina, really common to have sexual pain, really common to lose your libido. We sometimes lose our pelvic floor muscle strength, and we can get leaking and incontinence, and we're just not very good at owning up to this because it feels embarrassing and it feels shameful, but we need to talk about it because it's important. Before I carry on, I do also want to emphasize that menopause is an intersectional experience. It's not a one size fits all. We all experience menopause in different ways. Our gender identity, our race, our age, our ability status, whether we're living with other long-term conditions, whether we are neurodiverse, all of these things are going to shape how we experience menopause, and it's really important. Before I carry on, I do want to just signpost you to this amazing podcast. So Karen Arthur is an artist. She's a former teacher. She hosts this podcast called Menopause Whilst Black. She's been a real activist in this space in the UK to get people to talk about the experience of Black women going through menopause. And if you're interested, find her podcast. It's absolutely amazing. She's brilliant and like properly iconic. Let's try and get this down. Okay, so let me talk to you about HIV and menopause. The reason we're interested in this is, so this is data from the UK, is that more and more people are living with HIV and getting older, and that applies to women. So here in the red bar are women aged between 45 to 56 who are accessing HIV care in the UK, and you can see this massive increase in the number. So, and that is a good thing. We always talk about HIV and aging as though that's a bad thing. No, it's not. It's a great thing. It's a great thing to celebrate. I started working in HIV in the early 2000s, where people weren't living until their 50s and 60s in great numbers. So to be in this era where women are reaching a menopausal age, I think is something we should really be celebrating. But it does require us thinking about what it means to care and provide care and support for women living with HIV. For a long time, we focused on pregnancy and contraception. And yes, those things are really important. But the vast majority of people living with HIV, women living with HIV, are going to be in this perimenopausal, postmenopausal stage. And we need to really start thinking about what are their needs? What do we need to talk about? How do we prepare people for this change? So let me tell you a few facts. So first of all, timing of menopause. There is some, well, the data on whether menopause is earlier in women living with HIV compared to those without HIV are a bit mixed. Some studies say yes, some studies say no, there's not much difference. So we don't really know for sure. What we do know, though, is that the risk of very early menopause, so menopause under the age of 40, seems to be more common in the context of HIV. And I suspect, although I cannot prove that, there's not much data, that women who are born with HIV, I suspect, are more likely to go into an earlier menopause just because of the effects of HIV on the ovaries. And I think, having spoken to women who've lived with HIV for a long time, especially those who are born with HIV, that seems to be the case, and that they tell me that they're experiencing menopause at an earlier age. What do we know? We know that menopause and HIV does bring with it some slightly increased risks. So women living with HIV going through menopause have an increased risk of bone disease. So things like osteoporosis, which is more fragile bones and bone fractures, more risk of heart disease than men living with HIV. We're not very good at acknowledging that. Menopause increases the risk of tiredness and chronic pain in women living with HIV. Women living with HIV are more likely than those without HIV to experience hot flushes, and there's clear impact on mental health. And when you think about the poor mental health burden amongst women living with HIV, it's not surprising that when you add menopause to that, that your mental health is going to deteriorate further. So we know that there are increased symptoms. This is data from the study that I lead in the UK called the PRIME study. We collected data on nearly 900 women living with HIV aged between 45 and 60. 80% of them had menopausal symptoms. 90% of them had body-related symptoms like hot flashes, palpitations, joint pain. 70% had the genital symptoms like vaginal dryness, urinary tract infections, sexual problems. 80% had mood symptoms. But what was specific about women with HIV was the uncertainty. So you're getting these symptoms like hot flashes, like tiredness. They're not a million miles away from symptoms you might have from HIV or from your medication. So how do you begin to disentangle it? How do you know which bit is menopause, which bit is HIV, which bit is medication, which bit might be diabetes, and how do you know which physician to go to get advice? And I think that is that sort of unique experience of living with a long-term condition. Thinking about HIV and sex, we're not very good at thinking about sex in women living with HIV, and we're even worse when we think about women who are older. It's almost as though the world thinks that we all stop having sex at the age of 35, which is clearly not the case. So this is data comparing women with and without HIV. First thing to show, and these are women aged between 45 and 60. First thing is that regardless of HIV status, over half of women in this age group are reporting a problem with sex, which is something that we really need to take seriously, given that having sex for most people is an important part of their quality of life. What you find here is that women living with HIV are more likely than women without HIV. So by about 20%, they're more likely to have a sexual problem in the past year. And the impact of menopausal symptoms on HIV itself, on HIV care, are really important. So women living with HIV with more severe symptoms of menopause are more likely to miss HIV medication. They're more likely to miss HIV clinic appointments. They have worse mental health and a poorer quality of life. So at a very basic level, there is a really important argument, I think, for menopause to be integrated into HIV care, because you're not going to get HIV care right if you don't address this. And this is one of my participants from the study. So we did focus groups and interviews. And this participant is saying, if I wasn't coping with HIV and I was just dealing with menopause, maybe it would be easier, but I've got to cope with these two things at the same time. And if you haven't slept for the whole night and you need to take medication, it just gets so annoying. And imagine that with brain fog as well, where, you know, I don't know about anybody else on this call, but I habitually leave my keys in my front door. So imagine then the anxiety if you know you have to take medication every day as well. And when we did this study, we found also that nearly 50% of women said they did not have sufficient information about menopause. And what our participants were saying was, come and talk to us about it. We need to know. And this is a slide that I think I can be really proud of, that in the UK, we have changed. We have got menopause on the agenda. We have clear standards across the UK. We have clinics that are giving menopause related care. We have some amazing peer support groups and resources. So I think in the UK we have made great strides, and I would hope that this data is from 10 years ago. I think this would change now. We also know that menopause brings with it an increased risk of other medical conditions, so weight gain, cardiovascular disease, diabetes, and this is a result of the loss of estrogen, and that's regardless of HIV status. So what can we do about it? And I'm going to wrap up in the next couple of minutes. So what I really advocate for is for person-centered menopause care, and I'm a huge believer in integrating that within HIV services. I really believe that in the same way that we provide specialist HIV pregnancy care, we should be doing the same for menopause, because most of my patients really value their HIV clinic. They know us, they trust us, they've been coming to see us for years. They know they can talk to us about things that perhaps are a bit stigmatizing. So things like vaginal symptoms and sex. We are so well placed to provide this kind of care. So what can we do? Well, number one, we can think about menopausal hormone therapy, MHT. It is underused in general, and it's definitely underused in HIV. So this is giving back the hormones that are lost during menopause. So giving people back the estrogen. It is safe and it is effective. There is a slightly increased risk of breast cancer, but there is a reduction in risk of osteoporosis. It probably improves cardiovascular disease. And what it does is it gets rid of loads of symptoms. And I would argue that if you are not sleeping and you are having really, really severe menopause-related anxiety or hot flashes, getting rid of those is probably worth taking a slightly increased risk of breast cancer for a couple of years. So I'm not going to say that everyone needs to be on it, but I really do think everyone needs to be informed and have a conversation about it. It will improve symptoms, it will improve quality of life, and we can definitely manage any drug interactions with antiretroviral therapy. The one thing we should definitely be giving women and talking about is vaginal estrogen, either as a cream or as a pessary, so as a tablet you put into the vagina. That has virtually no side effects. It doesn't interact with anything, and it will get rid of any vaginal symptoms. And I just think we need to have that proactive conversation with every woman that we see, because people feel embarrassed talking about their vaginas. This is just data from the UK summarising the risk of breast cancer, because people are really nervous about breast cancer, and understandably so. So here, if you look here, this is the baseline risk. So in the UK, if you take 1,000 women, 23 of them who are aged between 50 to 60 will develop breast cancer in 5 years. If you take all these different risk factors, so here you've got women on hormone replacement therapy, so menopausal hormone therapy, an extra 4 women over 5 years will develop breast cancer. But if you compare it with other common things, so people who are living with either overweight or obesity, or people who drink more than 2 units of alcohol per day, those are greater risks. And here you can see that there are fewer cases of breast cancer if you take moderate exercise. So there's lots of things that you can imagine that if you take hormone therapy, that you might be more likely to go out for a walk and to be more physically active. So it might counteract that risk. I talked a bit about vaginal symptoms. There's lots we can do. So basically, when we go through menopause, we've got estrogen receptors all throughout our vagina. Basically, the vagina muscle becomes thinner and drier. And the way we can fix that is by using vaginal moisturizers that don't have any estrogen, vaginal estrogen, using lube during sex, and all of these things are safe and effective. And one final thing really to just remind people is you can still get pregnant when you're perimenopausal. I am definitely evidence of that. I had my youngest baby when I was 43 and perimenopausal, thinking that there was no way I'd get pregnant. So here I'm speaking from experience. She has been a great gift to me, but it was definitely a surprise that I wasn't intending. So you need to be using contraception if you don't want to get pregnant until you haven't had a period for 12 months, because the fastest rise of unplanned pregnancy is in women aged over 40. And lots of physical things that we can do. So thinking about our lifestyle stuff, staying physically active, staying well hydrated, prioritize sleep, try not to smoke, eat a balanced diet. I don't know what that is. We definitely don't need to clean and launder more. Ignore that. Stress relief, mindfulness, meditation, all of these things can really, really improve our health and our menopausal symptoms. So things we can do for ourselves. One of the best things you can do if you don't do anything else, start lifting weights. Lift weights, just lift, as my trainer in my gym says, you've just got to lift heavy shit. When you basically reach your 40s and 50s, it will increase your lifespan. It will stop you from getting osteoporosis. It will just keep you stronger for longer. So really just lift weights. It's the best thing you can do for your health when you're in your 40s and 50s. Here is an amazing leaflet from the Sophia Forum. Sophia Forum is an HIV charity for women in the UK. It's an HIV specific guide to menopause for women living with HIV. I can share it in the chat later. Just read it. It's great. I share it with everyone. We have developed in the UK a peer support program that's specifically for women aging with HIV. So these are trained peer mentors, women living with HIV who are in their 40s and 50s, who've been through menopause, who have undergone specialist training both in peer support and also in menopause and age-related issues. And we have 50 GROWS mentors throughout the UK now. I'm just about to have a GROWS mentor start working and doing my clinic with me, which will be amazing. So I'm going to end here by saying menopause is a natural process for most of us, but it's one that can be challenging. People with HIV may face additional challenges. It can have health, social, relationship, and work impacts, as support and treatment is important. Now, that may or may not include hormone therapy, definitely includes education and lifestyle changes and lifting heavy stuff. And it works. Like if you do stuff to address menopause, it works. This is one of my patients who came to see me, really, really suffering with menopausal symptoms. We had a conversation. I gave her information. She decided she wanted to take hormone therapy. She came back 3 months later and said she felt like she had her life back again. It's like transformative for her, just having that information. I'm going to end there and let me go back and stop sharing my screen.
I think
that's everything. I'm sorry that took a bit longer than I expected. There's so much to say.
Okay, so first of all, everyone, please a virtual round of applause in the chat. I have been moderating for a while now, and I do this often. And I have to say, I believe in giving my flowers, giving people their flowers when warranted. And this was one of the best presentations I've seen in a long time. It was so informative. I felt seen. I felt recognized. And I think that is why this is so important to do, because oftentimes women underreport symptoms for fear of sounding crazy or for fear of sounding like a hypochondriac, or right. And so all of the things that you presented are knowledge that we need to have. And I mean, I feel like we could end the webinar. We won't, but I feel like we could end right now and people would walk away feeling better informed. So thank you, thank you, thank you, thank you, thank you. I was looking at the chat and folks were are agreeing. I got text messages while you were talking about how amazing you were doing. So just know we fully appreciate this. Thank you. And so we're going to jump into some questions right now, unless someone on the panel wants to add a little bit onto what I said.
Yeah, so amazing. Oh my gosh, I the whole time, but like the overarching reiteration of like we don't talk about our vaginas because society tells us that that's embarrassing. And that is just like, that is rooted in misogyny and like colonization and our entire, that's been created for us to believe that we can't talk about our vaginas. And so research isn't being done about our vaginas. And so we are not able to be well informed because they don't really know. And it becomes a taboo thing. And so the fact that people, that we are here having these conversations and talking about our vaginas with importance, that's like more of this all day, more of this. And thank you for that. Yes, absolutely, absolutely.
I have a
Absolutely.
I have a
Go
long
ahead.
running joke with I don't know, do you know Susan Cole-Haley, the UK HIV activist?
I don't.
She's amazing.
Okay, well,
Anyway, Susan and I have a long running joke, which is who's going, Olivia knows Susan. We have a long running joke is wherever we go to give a talk, who is going to be able to get the words menopausal vagina into the talk first?
I
And
love
so we
it.
have this competition wherever we go
Amazing.
to try
I
and
love it.
get it on. You're right. We need to talk about stuff like this
Yep,
because this matters. It really matters to us. We do not stop having sex when we hit 35.
absolutely,
Yes. And
absolutely.
not just that, but I don't know about anyone else on the panel, but I'm definitely having the urinary changes.
Yeah.
Like
Yes.
it started out just, if I would cough too hard or if I would laugh too hard. But
Yeah.
now, like, and I'm not embarrassed about it at all. It is the fact.
Mm.
Like now, when I gotta go, I gotta go. If I sit here for too long or try to ignore it, like as a nurse and being on the floor and taking care of patients, I can't tell you how many times I held my pee for hours.
Yeah.
And when it first started happening that I couldn't hold it anymore, I was like, what is this nonsense? But again, that was one of the things that started happening to me, but I didn't realize was menopause,
Mhm.
and or perimenopause rather. So absolutely. Let's jump into a couple of these questions that we have.
Mm.
Um, and again, panelists, feel free to jump in at any time. Some of these are a little more technical, but we definitely want to have an open conversation about it. There was one in the Q&A that I want to ask. An anonymous attendee asks, she went in for fibroid surgery, removal surgery when she was 30 and never got her periods again after the surgery. Do you think the surgery trauma may have induced early menopause, although she never felt any of the symptoms mentioned in the slides? Can one go through menopause without symptoms?
That's such a good question. So it really depends on what the fibroid surgery was. So, for instance, you could have had a hysterectomy, which is where the womb is completely removed, and then, of course, there would be no more periods. What people don't realize is if you have a hysterectomy, that can sometimes induce menopause, even if the ovaries aren't removed, because it interrupts the blood supply to the ovaries. And people often forget that. So that's one thing. Could it be that if you've had fibroid removal, which is not removing the womb itself, but just removing the fibroid, should that induce menopause? It probably shouldn't. However, there are some medical treatments for fibroids that induce menopause. So it really depends on what the treatment is. If it is unrelated to fibroids, then what I always say to people is ask your mother when she went through menopause, because the single most important predictor of when you go through menopause is when your mother went through menopause. There is such a genetic component to menopause. And so it could be that there was early menopause as a result of that. Can you go through menopause without symptoms? Absolutely. I don't want anyone to come away from this slide, especially if you're younger and you haven't reached this stage yet, to think, oh God, it's going to be awful. I'm going to get all these things. There are some people who have no symptoms whatsoever, some people who have some symptoms, but they're mild, and some people who do have severe symptoms, but there's loads we can do about it. And there is a life beyond menopause that is so rich and so empowering. And we are doing a bad job of talking about the positive aspects of going through menopause and what it is to be a wise older woman with confidence. So I worry that the younger generation, we've gone from never talking about menopause to talking about it all the time, certainly in the UK, but talking about it in a very negative way. And that is scary for people. It's a natural process. There are positives, there are negatives. It's part of life. It's a rich tapestry. But yeah, you could have gone through menopause without any symptoms whatsoever.
Well, thank you for that. Kim, do you have any specific questions right now?
No, I just wanted to say thank you because I'm out myself. I was the one that text Bridget. I don't know if Bridget got any other text. I was like, this is bringing me so much joy, but then also sadness. I was like, Jesus Lord. But it was like, yes, we're having a conversation without making me feel like I'm crazy because I'm still in my 30s.
Yeah.
And I'm like, everything that you said, plus a couple more. And I had to refill my water cup 3 times because the dry mouth that I get, it was just
Yeah.
like, we don't talk enough about that. And I have never drunk this much water in my life over the last like few months. It's like, what is going on? Why am I always thirsty? But yes, thank you. Um, I needed this.
I'm so
Absolutely.
glad.
Symptoms. Okay, that's actually one of the questions that I have been wanting to ask.
Mm,
There are a lot of symptoms that folks don't recognize are actually perimenopause, menopausal symptoms. I did not have hot flashes. I'm one of the ones that did not. And so, what are some of those other the random things? So we know about the brain fog, we know about the fatigue, we know about the hot flashes, but like, for example, Kim talking about dry mouth, are there other symptoms that you have heard of as you treat patients that come up?
yeah. My rule of thumb is if I see a woman who is perimenopausal and she has symptoms, her symptoms are related to perimenopause until proven otherwise, because we are just on this journey of understanding how important hormones are to our bodies and how estrogen is more than a reproductive hormone. We always think of it as just a reproductive hormone. It's not. So other things that I've heard, some of them are common and you may know about it, some of them not, the sort of weird stuff. Common stuff, mood changes. So for me, my first symptom of menopause was not hot flashes, it was anxiety. I was getting crippling anxiety out of nowhere and I did not understand it. It's like, you know what, my life is quite good at the moment. Why am I getting panic attacks for no reason? It took me ages to put two and two together to realize that that anxiety was coming from menopause because I didn't have the hot flashes and I don't have periods because I have a coil in. So mood changes that aren't just the irritability, the going from 0 to 100. Anxiety for me was a big one. We've talked about brain fog, dry skin, really, really dry skin post menopause. And that's because we need estrogen in our skin. Hearing changes, so either hearing loss or getting tinnitus, the ringing in our ears. And it's because the tiny, tiny little bones in our ears become drier and stiffer when we don't have estrogen in them. And the thing is that we are gaslit when we go and see, and I can say this as a doctor, we are gaslit when we go and see doctors and we say, you know what, I'm getting ringing in my ears. And they're like, oh, it's probably stress. But no, actually, when you look into it and you understand hormones, you realize that these are hormonally driven changes. So yeah, those are some of the weird stuff. Weight gain as well. We're often told, oh, but weight gain is, it just happens because you're older. Yes, it does happen because you're older, 100%. But it happens more so during menopause. And that's because estrogen is really important for our metabolism. And when we lose estrogen, we lose the appetite suppressant effect of some hormones. And so we eat more. We can't, I definitely have eaten more in the past sort of few years, put on loads of weight. I don't need somebody to tell me that's all in my head or because I'm getting older. It is to do with menopause. So yeah, those are some of the things.
That speaks a lot to the gaslighting part of it. There's a comment in the Q&A where an attendee says that she's been to 7 different doctors and they all ignore her symptoms of perimenopause. They tell her to reduce her stress, which is minimal. And then when she seeks out a menopause specialist, they don't treat people living with HIV. And so one of our other questions were, what are the gaps in education for providers, for people that are seeking help in this stage of life? And then
Yeah.
secondarily for the panelists, what in your experience have you witnessed this or experienced this coming from providers? So Shema, you first. Are there specific gaps and how do providers address that?
There are gaps. There are gaps. There were definitely gaps in the UK before I started doing this work 10 years ago. I think we have addressed them in the UK. Um, there's going to be even more gaps in other places. Canada has been really good in terms of managing menopause and HIV because there's a really great Canadian group. There aren't there are some really amazing doctors working on HIV and menopause in North America. I can put their names in here, and some researchers. Sarah Luby, who I think is at Harvard, is doing lots of work in this area. She's amazing. What I would say, I hear this all the time where you keep going to doctors and they're dismissing you, and then you finally find a specialist and they don't want to look after you because you're living with HIV. And it's because they're scared. They don't understand HIV. They don't understand the medication we use. What I'm going to offer to you is I will put my email address here. If you find a gynecologist, that specializes in menopause, you give them my email address and tell them to liaise with me, and I can support them in your management. Because you shouldn't have to be waiting this long to fight for something that is actually pretty easy to manage. So yeah, I'm very happy to share my email address if it is helpful, and to support and be somebody that gynecologist can at least run the case by, so they have spoken to an HIV physician.
That is incredibly kind of you. And I wish that there were more of that liaise between clinicians. Ms. Dottie, we haven't heard from you yet, so I'm going to ask you about your experience dealing with your perimenopausal symptoms and clinicians.
My goodness. Thank you for even the the nudge for me to fix my face, because when you were talking, Shema, I was like, oh my gosh, like I'm like blown away. And some of the things that I've experienced in this perimenopausal phase is like I get the night sweats. You're like coming out of like your pajamas and then you get cold. So it's of course that. I don't, and sometimes it's concerning with some of the symptoms because you don't know, for me, I don't know if it's due to like the perimenopausal or the medication or just aging with HIV, right? So I don't, the night sweats, is that HIV related? Is it perimenopause? Like what's happening here? Sometimes, of course, the mood swings, like, when you're intensely angry or you feel things in an intense way. Then there was another one that I experienced, which was like you talked about joint and muscle pain. And I try to do some of the things to like be healthy, right? Like hydrate, you want to exercise. And I remember there was a time that I was walking, and I'm all about making sure you have the appropriate footwear for the exercises that you're doing. And I kept feeling this pain like at the top of my foot. So I went to my doctor to say, like, hey, what's this? Oh, listen, it's probably stress. It's probably this. And I remember I started to feel pain going up like my shin. So I'm thinking maybe it's the exercise, but I don't want to stop the exercise because that helps my mental health and my physical. So everything is connected. And if I can be really honest, I went to my ID doc and she prescribed me like pain medication, but I wasn't in pain. Like it wasn't that kind of pain. It was like, you know how when your foot falls asleep, and I kept feeling the tingling going up like my shin. And I was like, okay, what is this? And I'm going to say this. I went to, because I see a chiropractor just for general, like, well-being purposes, not because I had an injury. And I said, listen, I need you to do something. I don't even know what you're going to do. And I remember like him doing adjustments. And I promise you, within like 2 weeks, the pain dissipate, like the tingling stopped. I could feel it gradually going back down the shin. And I was like, this is interesting. Meanwhile, I had a prescription for pain medication that would cause me to be drowsy. And I have the type of life like many of the folks here. I don't have time for that. Like, I need to be alert and ready and engaged. I don't have time to be drowsy on top of like not getting the proper sleep that I need because of what's happening too. Like, I just don't have time. So I feel like you have to be your best advocate in these spaces. And I remember even with my GYN, I was like, all right, what's happening? Because there would be like some months where in terms of the menstrual cycle, you're like, where am I? And I remember her doing some blood work and she was like, oh no, you're not in menopause. And I'm like, no, I get that, but there has to be a reason why, like, I'm experiencing these symptoms. So just doing my research, talking with other folks, being in webinars like this is very helpful. Because like bulbs were going off in my head as you were speaking. And I just thank you for that. I thank you for that specifically with women who are living with HIV, right? Because we hear about it in like spaces that's non-HIV related, but then how do we deal here in this space? So thank you for that.
You know, Dottie, you bring up a really good point about, is it the menopause? Is it the medication? Is it the aging? And I think that a common thing that I have heard as I've been getting into this work is that women think that their symptoms are HIV related before they consider menopause, no matter what age they are.
Yes.
And I think that that's part of the reason that we need our clinicians to be more well versed in menopause, because that would have eased so much of my anxiety. You know, I
Mhm.
was convinced I was having some weird breakthrough opportunistic infection, even though I was, you know, undetectable and had, you know, I'm not, I take my meds most of the time, right? But just feeling like there was something, I was crazy and like it had to be the HIV, even though HIV and I had been living peacefully together for all this time, and now all of a sudden you want to act up, but it was menopause. And so thank you for bringing that kind of comment into the
You
space.
know what, Bridget, real quick, and then even with the inflammation, because you also think that's HIV related, and it could be, right? Because depending on where you are in your HIV, um, depending on where you are, like it could be those organs working overtime, but the inflammation and the weight gain is two of the things that I have had concerns about. So yes, thank you for that.
Um, Rebecca Dennison asked in the chat, she's still having hot flashes 10 years after menopause. Will they ever go away? And Shema, I heard you say during your presentation it can last, is it 4 to 8 years?
Yeah, on average, 4 to 8 years, about 10% of people will experience menopause symptoms for longer. So if you're experiencing them for 10 years or more, you are falling into that minority, but it is real. People do experience menopausal symptoms for longer. And again, depending on how much they are bothering you, it may, I mean, if they really bother you and interfere with your day-to-day life, that is a conversation to have with somebody about whether hormone treatment is something worth trying. What I always try and say to my patients is that starting hormone treatment is very, very different to antiretroviral therapy. When you start anti-rets, you know, that's like a lifelong commitment. You have to take them every day. We know that. It's different with hormone therapy. You can start it and you can stop it, and you can start it for, you know, I usually say, look, take it for 3 months, see what happens. If things get better, then we know it's menopause. If things don't get any better, then okay, we've given it a go. If you miss your hormone therapy, nothing bad's going to happen. So it's much more forgiving. And I think that's really important to emphasize with women, because especially with women with HIV, because there's so much emphasis on medication being lifelong and having, you know, excellent adherence. And it's to just emphasize hormone therapy is not in that same category. It's much more flexible. So yeah, you can have symptoms for longer than 10 years. It's a minority. And if it bothers you, you definitely need to be having a conversation about hormone therapy, depending on what those symptoms are.
Thank you for that. Ladies, I have a question for you from my wonderful panelists, and I'd like each of you to address it just a little bit, because one of the things that gets affected heavily while we are in perimenopause and experiencing this is our interpersonal relationships, that rage, that increase in anxiety. For me, my depression has increased and gotten worse. And so, how are you all managing your interpersonal relationships, knowing that this is it? Are you talking about it to your loved ones and your friends and family, or are you just kind of what? Heather, let's start with you.
Um, Wow, it's a lot. I had a really unique experience of having two children pretty close together and breastfeeding them for 14 months each, and then not having a period for 2 years, like no period at all. And then following that, I sought care and I went to providers. My ovaries woke back up and I menstruated for 3 months straight. And I remember laying in bed and the moment that I was feeling the hormonal shift of me starting to menstruate and the darkness that came into my mind was like, it's like it wasn't even me, but the suicidal ideation that I experienced in that moment was like, it overtook me. It completely overtook me. And, you know, I I have been in a situation where I have shared, space with someone for 12 years and I've been in cycles of being gaslit. So I get into my head about like, well, I'm crazy. I was after my son, I was diagnosed with bipolar disorder and, I was given this like long, you know, sort of like just details of what was going on with me. And it was really hard to hear. And I was put on antipsychotics for 2 years. Um, and I completely lost my identity. I was blank, and nobody ever was like, let's consider hormones because, as a person living with HIV, even though we're undetectable, our body is still experiencing low levels of inflammation, which is, we are aging faster. And so people with uteruses are going through menopause sooner, but that's not, providers don't know that. And so, yeah, it was really hard. It was really hard. I'm a single mom with two kids, and I try really hard to like that, like how you're saying the rage, like you don't want to present that in front of your kids or like the sadness and the darkness. But it was like, it didn't matter because I still had to wake up and I still had to go to work and make the money because I have to pay the bills to keep my water on. And then like, I have to parent my kids and be there for them and like continue to show up for them. And but I just like, yeah, it's like I wasn't even there. I ended up like going to a park, taking the kids to the park after school and ordering a pizza and sitting down and like I had disclosed in my chart that I was experiencing suicidal ideation because I was reaching out for help. And I got a call and was told that like that there's potential that I would lose my children and that I was going to be like, they were going to put me into like an institution and they said like they told me don't put suicidal ideation in my chart, right? Like they told me like don't do that because that's not a good situation because you're going through a separation and like you will lose custody of your kids. And I know I'm an excellent parent. I was made to be a parent. Um, and so the fact that I was feeling that darkness and I needed help so bad and providers just gaslit me, I mean, that's what causes disconnect and that's what causes people to unalive themselves because they literally like don't know what to do. And the demand for what you need to produce on a daily basis, depending on whether you're going through perimenopause or menopause, doesn't change. You still have to get the shit done or you'll lose your job. If you show up and you have brain fog, you're not meeting an expectation. You didn't do well enough. You know what I mean? And so it's hard. It's hard and we're not like, no one's talking about it. And it honestly, it really pisses me off, you know? And
Yeah,
so I'm really glad that we're having this conversation together and we're bringing this to the space because it's real and it's not fair.
yeah. And Heather, I just want to say it takes an amount of vulnerability and strength to be able to talk about those things openly. And so I appreciate you doing so. especially in this space, because other women need to hear that they're not by themselves, right? Like the that we're not crazy, that the emotional stuff that we're feeling is, it's emotional because it's hormonal, right? It's things that we're feeling. So thank you for sharing that. Kim, how about you? How are you dealing with interpersonal relationships as it relates to perimenopause and all of the things?
Well, first I want to give Heather a hug. So Heather, when I see you, I owe you a hug. I owe you a hug. How am I dealing with tequila? Tequila. This is a safe space. That's tequila and weed. I'm being honest. That's where I am. Um, and I'm not so much on the weed. It's more so tequila. Because I can't sleep. Um, the anger, the rage. Uh, I go in my car. So I take walks in the morning when I'm not working at the school because people trust me to be a teacher. So I'm teaching the kids. So I wake up early in the morning and I listen to music and that grounds me. Um, Before I snap, I have to check in with myself. And that's only, I want to say maybe I got 2 good weeks out the month where I am able to check in with myself. That third week, it's over. Right before my period, there's no checking in. I just think almost all of my circle knows when my period's about to come on now. And this is a new experience for me, because I haven't had a period I've been on birth control for 10 years. I just recently got off of birth control, took the implant out June. So now my body was getting adjusted to not being on birth control for so long and then getting an actual regulated period and it's still not regulated and it's almost 6 months. So it's a guessing game of when am I going to get my period, even though I have 5 period apps. Um, is this 21-day cycle? Oh, we just made it to 25 today, just made a 25-day cycle. So I'm like, okay, this is going good. And as I'm know for a fact I'm going through perimenopause. So I'm like, I think I started a series, but then of course, I'd be forgetful because I have 8 million jobs where it was like, is this perimenopause? Is this my period or am I dying? Because I didn't know, is this my HIV? Like y'all said before, is this perimenopause? Why am I so angry? Why can I not keep my thought together? Is this because of like past problems that I've had? Because like I had a stroke like 6 years ago. So I'm like, is this neurological? Is this part of that? Like, is this like what is it the HIV? And according to my doctor, I'm too young to go through perimenopause. And I'm like, no, 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 it's not it. Especially when we don't have no data for those who are born positive. So we're already not talking about perimenopause. This is a new conversation. Um, then perimenopause and menopause with women living with HIV. This is fairly new. And then lifetime survivors with early onset. So we're just uncharted territory. We're just going blindly figuring this out. And I'm diagnosing myself like, hey, I have a list. This is what's going on. It's like maybe it's your HIV. Everything cannot be my HIV. Like that was my last doctor's appointment where I started looking at my doctor different. Like, is it because I'm not on meds? So it's like it has to be your HIV. Let's talk about meds. No, this is serious. I'm like, my hair's changing now. And I'm thinking if everybody knows me, I've been coloring my hair since I was 12. So I'm like, my hair texture changing. I don't got this problem. I think it's perimenopause. Could be HIV. It's not HIV. Let's not do that. I think it's something else. I think it's the hormones. Let's talk about HIV. So I think me trying to manage is again tequila, um, my 5 hours of sleep, um, talking to my circle, and all of us venting out with each other, all of us giving each other grace. My circle is now a square. It's not because I just don't got the patience for other people's personalities that has shrunken. Um, So yeah, and having these conversations and not feeling like I'm going crazy because
Yeah.
for a really long time, like I felt like I was going crazy. My husband just experienced the hot and cold flashes, and one day he made a joke about menopause and said, "You going through menopause?" I said, "It's actually perimenopause." And then I'm like, "It's hot," so I put the AC on, and then he cut it off, and then I'm in the car and the heat's on. It's 85 degrees in the car, and
Yeah.
it was still nice outside. Like it was like maybe 40 degrees outside. I'm in New York. And I'm like, usually I'm like, this is wonderful. And I'm like, oh my God, I'm so hot. Like, and I shouldn't feel like this. And it didn't feel like a safe space. So I'm happy that um y'all are offering a safe space for us to have this conversation. And I'm gonna stop.
Thank you for that. There's a couple things that I think that you said that are important. One of which is that women are storytellers, and we talk to each other about what we're going through. And that's a beautiful thing, but it doesn't do us any good if we don't have the proper tools and knowledge to really be able to help each other navigate through things. And so, again, part of the reason why we need to make sure that our clinicians are informed and listening to us and hearing us, and really that our family is listening to us too. So, thank you so much for that. Dottie, how about you? Anything to add to that?
Yes. Let me just say, I just appreciate both Heather and Kim just for your honesty and vulnerability in this place. Like, thank you for that. Like, thank you for that. Um, in terms of my interpersonal relationships, so I think I mentioned that I turned 50, and it's a big deal, and I'm gonna keep saying it until I turn 51 and 52, right? Because a lot of my friends they were also turning 50. So we're experiencing a lot of the same things at the same time. Some of my friends are further along, like the one who continues to brag that she hasn't had her cycle in like 12 months and she's legit in menopause, and I'm over here suffering in a different way. Um so we kind of support one another, and we try to find resources that will help one another. But in terms of like on the home front, like with my husband, I'm reminded of something I heard a few weeks ago, and they talked about like the hormone that allows you to care diminishes, right? So like you get to a place, like I'm kind of like the matriarch in my family, even though like my mom is here and I'm the go-to, right? And so I'm also feeling like that, hey guys, like I'm gonna just let you deal with what you need to deal with. And so like the caring, that ability to care in the same way looks very different. And of course, folks are looking at me like, oh my gosh, like you were the one. And I'm like, listen, I can't oh my God, I can't like stop or get in the way of your suffering. Like if this is where you want to be, like I'm going to give you what recommendations I have, but I'm not as invested as I used to because I found that I was an overfunctioner. Right. And I was in usually when you're in relationships where you're overfunctioning, there's somebody in a relationship who is underfunctioning. So I'm starting to see like that letting go is a part of the narrative at this point. And my husband is pretty understandable. And also another thing that helps me to cope is really looking inward at this point and like really pouring into my cup. And I think that was one of the things that I around the time of my birthday, I was like, listen, I need to do me, right? Because I will go to the moon and back for everybody else, and I will always put myself last every time. So now I'm making myself a priority. I want to say that I have like 31 days, good folks, and exercising for like 30 minutes, right? Like so I have like my little things that I have here that I work out, like my Peloton, and I'm locked in every day for 30 minutes, even if it is a sleep meditation. Like I'm locked in. I'm like, listen, sometimes that's the best I can do. Because what I've realized in this process is that my best fluctuates from day to day. And some days I'm able to give you 1,000, and then today is 99. But that's my best. And I can assure you I'm giving that to you as my best. But I also want to make sure that I'm being me to me, right? Like I'm being me to me. Like I'm going all out for me. Because I'm worth it. And I feel better when I do that. So that edge, it feels different. Like when I'm exercising, it that intensity of emotion is different because I'm finding ways to like work it through.
Yeah. You
That's
definitely
what I
have
have.
some from Kim and Heather on the I can only give you what I can give you today. And you know, capacity diminishes or changes as our body changes and as we deal with the ebb and flow. Um, and as as all three of you were talking, I was just thinking about ways in which we identify um, our emotions and how we identify how we are dealing with other people. And so thank you all for that. And again, for being vulnerable. I think it's really important. Shema, I have a question about identifying menopause. Are there labs? Because, and I'm asking because I know the answer, because that's what helped me. There are labs that folks can use to identify kind of where they are, right? And so can you talk a little bit about that for
I,
folks that are
yeah,
listening?
I can. And really just echoing what Bridgette's just said, thank you so much for your sharing. And I'm not living with HIV, but I empathize 100% with so much of what you're saying. And it's a shared experience. And, you know, that experience of the effect. I mean, I don't think me and my husband have ever run into as much trouble as we have done in the past few years. And that is because of the impact of menopause on every single aspect of myself. And also, Heather, I hear you. My children are the same age as yours. And it is hard to show up and parent when you have little kids and you are raging, but you want to be the best parent you can be. And you want to break the sort of generational trauma that there might be in your own life. And, you know, hats off like to those of us who are parenting small kids at this stage of life. It is tough. So how do we diagnose menopause? I'm going to tell you that labs are not helpful unless you're under the age of 45. And the reason is that once you're 40, if you're 45 and you have menopausal symptoms, then 9 times out of 10, the cause is going to be menopause. If your periods are irregular and you are over 45, you are going through perimenopause. And the problem with doing labs is because your hormones are going up and down and they're not reliably sort of low, you might get your labs done on the day that your hormone levels are normal. And that doesn't mean that if you repeated the labs the next day, that the blood work wouldn't show menopause. So what I worry about is relying on labs when you're over 45 might mean that the labs come back normal and a doctor who doesn't understand menopause says, oh yeah, we've just excluded menopause. So for me, the way you diagnose perimenopause in women over the age of 45 is by taking a good clinical history, listen to somebody. Is what's happening to their cycle? What kind of symptoms are they having? If I see somebody who is over 45, who's getting hot flushes or mood changes or is tired, etc., what I might do is do a thyroid function because your thyroid tends to go a bit haywire at this stage of life. But it's going to be perimenopause, and I will have a conversation about lifestyle and reducing stress, and I will talk about hormones. And as I said, try hormones for 3 months, see if it makes a difference. There, you've got your answer. Under 45, it's different because the chances of you going through menopause when you're younger are smaller. And that's when, if somebody has either perimenopausal symptoms or their menstrual cycle is irregular, then I do rely more on labs. So hormone testing over the age of 45, don't do it because it may give your doctor false reassurance.
Thank you for that.
I have a question.
Yeah, this time is flying by. Do you
It
realize we
is.
are almost out of time? And we could go
Okay.
on forever and ever and ever, right? Like it's crazy. I actually want to, but we need to respect folks' time. And there were a couple more things in the Q&A. One of the questions was being able to request disability for severe menopause and stop working. I don't know if you can address or answer that. I'm sure it's different in the UK and here, right?
Yeah, I mean, in the UK, I don't know what, I can't imagine it's any better in the US, but in the UK, the UK government is really clamping down on what you're allowed to.
Did we lose your audio? I think we lost your audio.
You hear me?
There you go.
Yeah. I would have a discussion with your physician about how your menopause symptoms are impacting you, how they interact with HIV, how they interact with you taking your medication, and what recommendations they would give in terms of disability benefits.
Excellent. And then Rebecca says she heard Biktarvy can cause weight gain and menopause can also cause weight gain, but starting Biktarvy during menopause can especially cause weight gain. Is this true? It
Yes.
is in alignment with her experience. That's all we needed.
Yes.
I guess. And I appreciate you saying just a flat out yes, because so many times we get gaslit about return to health and all of the things and the exercise and the thank you. Nancy Mason says she had menopausal symptoms for over 10 years after being dropped into menopause following a hysterectomy at 41, and she was only offered counseling, which is a failure on the part of healthcare. So many, as I've been, because I've been working with Sarah Luby, you mentioned her, she's amazing.
Yeah.
And as I've been working with her and listening to women talk about their stories, women living with HIV have faced so much discrimination and bias and in healthcare. You know, there were women who had forced sterilizations or sterilizations pushed on them because of their HIV status. And so that's why it's so important for us to be able to be in community together and have open and honest conversations about what we're feeling and what we're doing and how we're managing.
I agree. There's one group of people who I think are often left out of this conversation because people often say, oh, isn't it great because you've gone through menopause and you can no longer get pregnant? And we forget about those people who desperately wanted to get pregnant and who weren't able to for lots of reasons. And to be childless, not through choice, and going through menopause, I think is a profound grief that we don't talk about enough. And I get really cross when doctors talk about how, you know, menopause is really positive because you can no longer get pregnant, because that is not a positive for some people. That is a deeply painful grief. So I always want to honor those people who are going through sort of childlessness not through choice and transitioning through menopause. It is very painful.
Absolutely. And the other group I think that gets left out a lot is transmasculine folks.
Yeah,
in these
100%.
conversations. There is an amount of there's definitely lack of knowledge, but there's also, like we were talking about vaginal health, there's that amount of shame in talking about it or discussing it. But they are also another group of folks that deserve attention and need to be included in conversations. And that I think is where we come in as a community and as people who are talking about it, is getting the word out there and being able to have those conversations with our peers so that maybe they feel a little more empowered to be able to advocate for themselves or stand up for themselves or have these conversations. So thank you for bringing that that sensitive intersection in, because I think it is important to frame menopause as a positive thing and that it's not the end of our vitality. You know, men get more distinguished, women just age, which is an unfair narrative, because I think in many ways, women age better than men, more wisely than men. And so thank you for that. In the last couple of minutes, I'm going to remind and pretty please ask those of you who are in the chat to take our survey. The link is in the chat. It helps us with our programming. It helps us to know that we're delivering things that you need to hear about, that you want to hear about, and that we are actually helping our community. 10 seconds each. Last thoughts, Dottie.
I think we need to continue having this discussion. And just know that we're our biggest advocate. Like, do the work, right? Find the resources, but continue to advocate for yourself.
Thank you.
Thank you.
Kim.
I'm going to enjoy aging and going through reverse menopause, going through reverse puberty while my son is going through puberty as well. I'm going to enjoy this process.
Excellent. Reverse puberty. Love it. Heather.
I think like overall, I just think that society doesn't consider people with uteruses in the same way that they consider men, and that's the reality of it. And we need to continue to have these conversations and frequently, and you can fire your provider. And you can reach out to your friends and your family and your loved ones and your chosen family to continue to be loud. Because if we don't be loud, if we do not be loud about this, then we're just continuing the narrative over and over again. And it needs to change. So,
Excellent. Thank you. Shema.
I'm happy to do a part 2. I've just seen what Kim said. I'm always happy to come and talk. We need not to be ashamed anymore. We need to menopause loud and proud. We are important, valuable people. And this is a normal part of life. And I'm very grateful we live in a generation where this is being talked about, because this was not talked about by my mother's generation at all. So it is great that we're here. And just one small thing about the Biktarvy, it doesn't mean you don't take it, but yes, absolutely. There are data to show that people who switch to Biktarvy during perimenopause have increased weight. It's still a great drug. Had to say that.
Excellent. Thank you for saying that. I appreciate it. I appreciate all of your time, both the panelists and the folks who showed up on the webinar, in the chat. Thank you so much for being a part of this amazing conversation. I feel so full. And like I said, after your talk, I feel very seen. And so extending personal thanks, and then thanks from the Well Project to you for your time and your expertise and your energy. So thank you to everyone. Take the survey. We love you. Take the survey. Let us know. And short of that, have a absolutely wonderful, it is Thursday, yes? Have a wonderful Thursday. Be well, be blessed, and be safe heading into the holiday season. We'll talk to you soon. Thank you.
Thank you, everybody. Lovely to be with you today. Bye.
thank you.